have more to ask you, but we'll keep moving along. Next will be Dr. Todd Allen, who is a professor of medicine at Harvard Medical School and the Reagan Institute of Mass General Hospital, MIT, and Harvard. Dr. Allen's laboratory is particularly focused on understanding the immunological and virological factors influencing transmission and immune control of highly variable pathogens like HIV and HCV, and exploiting these findings to generate effective vaccine immunogens. Currently, his lab is applying next-gen sequencing technologies to characterize the boundaries by which HIV and HCV transmission and evolution is restricted and influenced by host antiviral responses. And I am quite confident that we'll all be excited by some of the results of the GHOST laboratory work that you've been conducting. With that, I'll turn it over to Dr. Allen.
Great, thank you, Wilson. And thank you for the opportunity to talk to the group today about some of our work. You know, the title here is really the title of the RFA that we all sort of ended up applying for, but the focus here is really around working within opioid injection drug epidemics and trying to understand and identify appropriate ways to prevent and treat. And, you know, we tried to come up with a good acronym for this and we really couldn't. So, you know, we really just refer to ourselves as the Rural Opioid Initiative. But importantly, it really does represent a collaboration across NIDA, the CDC, SAMHSA, and the Appalachian Regional Commission. And I think it's really been fundamental and important to see how all these different sort of clinical or on the ground sites are dealing with the opioid epidemic in their own way and some of the unique hurdles they have and some of the shared responses they've been able to generate to address it. This map just shows sort of the 8 different sort of clinical or on the ground sites in Oregon, Wisconsin, Ohio, New England, West Virginia, North Carolina, Kentucky, and Illinois. And each of those groups are sort of focused on enrolling individuals, testing for Hep C, respondent-driven sampling to collect information and to understand exactly what their local epidemics and transmission networks sort of look like. Our group here at the Reagan Institute overlays the GHOST lab, which is a sort of a tool that was developed by the CDC that we've helped to implement here across these different sites. And then we have a data coordination center up at University of Washington. So, you know, the focus of the 8 sites is really sort of a biphasic, multi-method research projects that inform community response and integrated approaches to prevent HIV and HCV infections among PWIDs in rural communities. And the first 2 years was really sort of a local community assessment of what their local epidemics look like. And then the next 3 years was really to propose and implement evidence-based practices to address opioid use and related comorbidities. And my lab here at the Reagan has really been focused on sequencing of the virus using next generation sequencing approaches and phylogenetic approaches to identify linkage between the different viral sequences to see if we can overlay and expand upon what the UH3 sites are doing, and to, you know, fundamentally try to understand, if we look at sort of a large cohort of people who have been HCV positive and look at the sequence and try to relate and understand where exactly certain sequences are showing up that are similar across individuals, and identify and ask whether or not molecular epidemiology can identify subjects infected with the same strain of HCV to potentially uncover patterns and networks of transmission that might help to inform local prevention, treatment, and control. And so I'm really going to focus on the molecular epidemiology aspect of all of this. And for those that are really, you know, more interested in this, I would point people to this, I think, wonderful review. And this is on HIV transmission and phylogenetic analysis. But I think a lot of the same lessons and applications apply. You know, I think we've been doing this for a number of years in HIV, and I think that's been very helpful for identifying exactly where transmissions are coming from. And as they point out in their review, in high-income countries, a lot of that transmission is between recently infected MSM, and really with a focus on the acute phase of infection when viral loads are very high and people are more apt to transmit. But it's taught us a lot about, you know, in the rural setting, especially in South Africa, where transmission between different communities tends to occur, and that indicates a lot of travel-associated transmissions that need to be contended with, as opposed to sort of a local community approach. And it's also certainly raised issues and identified the age discrepancies between men and women, where oftentimes older men are linked to transmission to younger women, and identifies, again, sort of different points where we can sort of intervene in more appropriate ways and identify exactly how transmissions are occurring in sort of local settings. They also talk about sort of the predictive value. I think if you can understand exactly where transmissions are taking place, there's opportunities to prevent infections, and you can sort of predict that, and that includes pre-exposure prophylaxis. And they also sort of point to one study, this is out of BC, Canada, in terms of a drug-resistant strain of HIV, and the opportunities to apply this type of approach to identify either larger networks of individuals that may be growing in terms of the spread of particular strain of the virus, or particular drug-resistant variants that might want to be headed off earlier. But they also touch on sort of the fact that this type of approach does require dense sampling of patients, and a small time gap between the point at which the sample was collected and the sequence data generated, and the need to really act on that sort of in a timely manner. And of course, the cost effectiveness of the approach needs to be considered in light of other intervention approaches. Now, with respect to the work that we've been doing with Hep C, the basic approach is that clinical samples are collected. In this case, they're collected locally. They're actually processed locally. They're then sent to our lab here in Boston, where we amplify a small region of envelope and then deep sequence that particular region. And the distinction here between sort of conventional Sanger sequencing and deep sequencing is sort of analogous, I guess, to Sanger being understanding what a book is about, and maybe a book about trains. But if you open up that book and read through it, you understand that there are actually thousands of different types of trains. And so while that's a book that's different about something than boats, we can get a lot more information, a lot more accuracy and stringency by applying the deep sequence data, where we can look at thousands of different strains of the virus in each sample that we look at. And so in this case, because of that sort of stringency, we can actually get away with sequencing a very small region, in this case, the hypervariable region of Hep C, which is its most variable region, but it's a short one, and therefore a very small PCR product that's much more amenable in the lab, both to amplification and to sequencing. And so sort of the best known example of this, I think, is in the case of the Scott County HIV outbreak, in terms of the application of HCV phylogenetics to understand that outbreak, which really grew from a small number of cases in January 2015 up to almost 200 cases by the end of the year. 92% of those cases were Hep C positive, and that indicated or brought to light the fact that there was really this underlying HCV epidemic that was, in essence, driving the HIV infections in the area. And also that there was really sort of a large cluster of about almost 200 individuals that accounted for about 70% of all the infections. And so the thought being that, well, if we'd known this at the time, could we have headed this off a little faster, not only knowing that there was an increase in HIV infections, but potentially exactly how and where that was spreading. Now, this is a very unique case because this is a very concentrated outbreak, a very fast-moving epidemic, and raises the question about whether this can be applied in sort of a more generic fashion, and in particular to sort of a rural setting. And so the approach we use is really predicated on a program that the CDC's hepatitis group had developed, which is called GHOST, which stands for Global Health Outbreak and Surveillance Technology. And it's really taking that sequence data, or that next-gen sequencing data, and applying a phylogenetic approach to determine which sequences are really and most accurately linked to one another versus those that would represent truly independent infections. And so our role here as the GHOST lab is to generate the sequence data and work with the CDC directly. So linking those UH3 clinical sites where they're enrolling patients and looking at RDS data and linking that to sort of the CDC's network and trying to apply sort of this molecular epidemiology. So our progress to date, again, across these 8 different sites, they've been able to collect almost 1,400 HCV antibody positive samples. And this is really an enormous amount of work. Again, these are sites that are already undertaking their normal research projects. And then we're also collecting and processing on site, and in some cases in a very rural setting, samples in real time. And so the blood samples needed to be collected through a local phlebotomist. They needed to be processed on site in terms of centrifugation and frozen and then shipped to us eventually. And so I think we uncovered a large number of sort of smaller steps, but nonetheless critical ones to sort of the type of enrollment or rollout that would be required to do this more routinely. We are also, in the case of Wisconsin, fortunate to be able to sort of pull back and look at some retrospective samples that were from the same area as their prospective samples that were being collected. And so of those 1,400 HCV antibody positive samples, we've been able to complete PCR amplification of the virus from just short of 1,000. PCR failed rate was about 13%, which is actually largely driven by antibody positive RNA negative samples, very similar to what Risha was noting. And so again, even there on the ground, our ability to distinguish between the antibody positive and a active RNA positive sample in real time is still a barrier. But we were able to amplify, well over 90% of those, and they were able to pass the metrics in terms of robust sequence data that was needed for the downstream GHOST portal. And so what does that data look like? So we can look at the case of Oregon. There were 42 individuals sequenced, 16 of those clustered, so 38% clustering. Those clusters ended up being largely dyads or pairs of individuals, which is actually pretty impressive in the sense of a small collection of 42 individuals. The colors denote the genotype of the virus that was the infecting genotype. But it also raises across each of these sites, as we look at Ohio, 10%, North Carolina, 35%, that there are differences in the rate of clustering, but that's also potentially largely influenced by the rate at which the patients are enrolled. You can imagine in a case where you may have one seed individual who goes out to invite other individuals into the trial, and they might bring in 10 people, or you might have 10 seeds which go out and bring in one individual each. And so the rate at which the patients are brought into the study can have a big impact on sort of the molecular epidemiology as well. And so that's something that we're trying to understand across these different sites that have different enrollment criteria and approaches, to what degree that's an influence on this. We can look at Kentucky and New England, where we see much larger numbers of samples sequenced to date and end up with very different levels of clustering. Again, 16% in Kentucky, 42% in New England. And again, the enrollment types that we think are probably one of the larger drivers, rather than there being sort of distinct microepidemics, if you will, within these two different areas. We can look at something like Wisconsin, where we'll be able to combine both the prospective and the retrospective data to look at upwards of 400 individuals. Here we can see that the rate of clustering is about 38%. So even though we've increased the number of samples dramatically, the rate of clustering is about on par for what we saw with New England. But we do start to see these larger clusters of 14 individuals, and we can sort of look back in time a little bit. And I think that's one of the powers of the approach, is that back in 2016, this actually represented just 2 individuals that were linked. In 2016, 2017, as we added more data, that cluster grew to 8, and then by end of 2018, we were up to 14 individuals. And I think this is sort of one of the potentials of this approach, is to identify these clusters as they grow and determine whether or not there's an opportunity to intervene with one or more individuals within those clusters to try to sort of short circuit that transmission chain. And maybe those are settings where a small amount of effort can lead to a larger amount of reduction in transmissions. We can also sort of overlay that with the respondent-driven sampling in terms of how individuals are perceived to be linked at enrollment. Here we're just simply demonstrating that we can confirm that the RDS data in terms of linkages supported by the viral sequence data. But we have a number of other examples where that data doesn't shore up in terms of the fact that there are cases where individuals may be deemed to be potentially linked through RDS, but in fact are not confirmed through sequencing. And so, to that end, we've been working with Kim Page and her group over a number of years on their UFO study. And this is a HCV You Find Out study of prospective observational study of HCV transmission and acquisition among young people inject with drugs. And, the key point of this study was to enroll those at risk for HCV or those that were seronegative viremic upon enrollment, and then up to 3 HCV RNA positive injecting partners. And, Kim's group then conducted a survey, a baseline behavioral questionnaire. And our role here was to sort of overlay the viral sequencing data to understand, in which cases was there direct transmission, or at least presumed direct transmission, and allow that to sort of further enhance the value of the RDS data in terms of understanding when there was an actual transmission event, and then what the RDS data would tell you there, as opposed to sort of assuming that all of the RDS data and individuals that were deemed to be sort of linked upon enrollment were actually cases where the virus was actually transmitting. And importantly, the partnerships were relatively loosely defined in this study in terms of the fact that they were asking for individuals that were injecting at least 5 times in the same physical space, that they were RNA serodiscordant upon enrollment, but eligibility didn't require actual sharing. And so if we look at that cohort here, this was 101 injecting partnerships, which constituted about 25 clusters. Majority of these were dyadic in terms of these partner pairs, or just a pair of individuals, but there were a number of other complex networks of multiple individuals. And notably, about 33% were in a sexual relationship. And so Kim's group undertook sort of a study to understand exactly what might be associated with potential risk for acute HCV infection, and identified 25 new HCV infections. And then if we take a look at the viral sequence data, we could generate sequence data from the core to NS2 region, a slightly larger region than I talked about earlier. And we generate sequence data from a number of these individuals, and then could, based on phylogeny, understand exactly which sequences were related. In other words, there's enough of an identity or identical sequence in 2 individuals to deem them have been infected with the same strain. And oftentimes we'll presume that to be a direct transmission, but it may well be that there's an individual or more in between those, but they are certainly infected with the same strain of the virus. And so we did that with one region of the virus with core to NS2. We could also do that with another region of NS5B. But in total, we identified that of those 25 new infections, 12 were phylogenetically linked to at least one partner, which also means that the other 13 were infections from outside of that originally identified partner pair. And then in terms of adjusting for factors that were associated with transmission, the number of days that the partners injected, an odds ratio of 1.07, ancillary equipment sharing, odds ratio of 5, and the index partner being HCV seronegative, but in the viremic phase, indicating that they were likely acute infection, but had not seroconverted. But interesting, HCV viremia was not also found to be associated. And we would interpret that to mean that, in fact, individuals that are in the acute phase of infection are more apt to transmit, although the fact that the viral loads can fluctuate quite dramatically within the acute phase is probably why we're seeing viremia as a cofactor that fell out. Now, we've sort of taken that another step farther in terms of looking more closely at the sequence data. So in addition to confirming 12 of those self-described partnerships by sequencing, we also identified 3 new links between individuals within that cohort, including one that was identified only through a minor variant that we would not have picked up with Sanger sequencing. But interesting, the partnerships were more likely to be genetically linked if they shared only one connecting edge, meaning that we sort of go back and look at the larger network. situations where there's really a case where the index patient only enrolls or self-enrolls one additional subject were ones where we actually ended up seeing that the virus was more likely to be linked in the individuals infected with the same strain, as opposed to sort of the larger networks where that the infection was often coming from outside of the pre-described partnerships. And we also saw a strong signal for linked partnerships to be reporting and engaging in a sexual relationship. Again, sort of driving towards the issue of the closeness of the relationship of the individuals. And I'll just wrap up with sort of this last part around dried blood spot, because I think it's something that we're moving towards in terms of feasibility. Sample collection, as I mentioned, and local processing was a substantial burden. And if we take a look at sort of samples from about 10 patients here, and we're looking at the amount of diversity within any given sample repeated from either the plasma sample or different dried blood spot approaches, we get very good concordance in terms of the ability of dried blood spot approach able to accurately collect the type of sequence data that we need. And so I think this approach is very feasible to dried blood spot, and certainly would pair with other approaches that dried blood spot could have in terms of the surveillance of Hep C. And this just goes to show a very strong concordance between those different approaches. So just to wrap up, the transmission network analysis is feasible across rural communities, but it is burdened by sample collection, sample processing, and shipping. And I think this place where the dried blood spot approach could really make great inroads. And there were significant delays in data turnaround, largely due to financial costs of the shipments. And so we tended to batch those, which limited sort of real-time implementation and follow-up. But I think there's a great proof of concept for scaling it up. We were able to identify a number of different clusters within the majority of the cohorts, and the clustering range significantly across cohorts, again, suggesting that there are other factors that may be driving the level of clustering that we see at each of these sites. And cluster detection is dependent upon sampling density, and I think it's a case of something that needs to be done at scale. But I think at that point, the cost of the approach can come down quite dramatically. And I'll end there. I think really the kudos go to the unique UH3 sites. I think they're the ones who've been really doing the majority of the heavy lifting here on this project, but also from my lab, Karen Power, Damien, and Jackie, and certainly the funding across NIDA, CDC, SAMHSA, and AR and the ARC. And I'll take any questions.